Venous pressure measurement is another blood pressure measurement we will discuss in this lecture. Measurements of venous pressure are an important aid to physicians for determining the function of the capillary bed and the right side of the heart. This is because of the low pressure value in these regions, in these sites. The pressure in the small veins is lower than the capillary pressure and reflects the value of the capillary pressure. The intrathoracic venous pressure determines the diastolic filling pressure or the right ventricle. The central venous pressure is measured in the central vein or in the right atrium. It fluctuates above and below atmospheric pressure as the subject breathes. Therefore, we should consider the breathing of the subject to measure correct values. Whereas the extra-thoracic venous pressure is 2 to 5 centimeter water above atmospheric. The reference level for venous pressure is at the right atrium. Remember that we need a reference level for the correct measurement of anywhere inside our body. We should select a good reference level for good recording, for good results in recording. In this slide, as you can see, central venous pressure are measured via a specific method. Central venous pressure is an important indicator of myocardial performance. It's normally monitored on surgical and medical patients to assess proper therapy in case of heart dysfunction, shock, hypovolemic or hypervolemic hyper, we need an extra an R here, hypervolemic states or circulatory failure. It is used as a guide to determine the amount of liquid a patient should receive, and also you can read the measurement method by yourself. Continuous dynamic measurements of venous pressure can be made by connecting to the venous catheter, a high sensitive pressure sensor with a low dynamic range than that necessary for arterial measurements, because the frequency components or frequency contents in this type of blood pressure is lower than we need in arterial measurements. Problems, we have some problems in maintaining a steady baseline occur when the patient changes position. Errors may rise in the measurements of the catheter is misplaced, or if it becomes blocked by a clot or is impacted against a vein wall. It is normal practice to accept venous pressure value only when respiratory swings are evident. Normal central venous pressure range widely from 0 to 12 centimeter water with a mean pressure of 5 centimeter water. Esophageal manometry uses a similar low pressure catheter system. This test will tell you, your doctor, if your esophagus is able to move food to your stomach normally. The next important subject in cardiac surgical is cardiac catheterization. The cardiac catheterization procedure is a combination of several techniques that are used to assess hemodynamic function and cardiovascular structure. Cardiac catheterization is performed in virtually all patients in whom heart surgery is contemplated. This procedure yields information that may be crucial in defining the timing, risk, and anticipated benefit of a given patient. Catheterization procedures are performed in specialized laboratories outfitted with X-ray or fluoroscopy equipment for visualizing heart structures and the position of various pressure catheter injection of radiopaque dye. In addition, measurements are made of cardiac output, blood and respiratory gases, blood oxygen saturation, and metabolic product. Clinician can also use balloon-tipped follow-directed catheter without fluoroscopy. The applications of cardiac catheterization can be categorized as follows. We can use cardiac catheterization to measure pressures across the four valves to determine the valve's pressure gradients. The gradients is important in the two sides of a valve. We can use it to measure cardiac output using the principle of thermodilution, using dye elution, the Fick method, and impedance cardiography. Also, measuring the gas O2 and CO2 in blood samples for shunts detection. And also the catheterization can be used for angiographic visualization. Cardiac catheterization can be used to enlarge the lumen of stenotic coronary arteries, and also can be used to assess valvular stenosis. Also, during heart catheterization, because of mechanical stimulation, some ectopic beats or cardiac fibrillation frequently occur. For this reason, a clinician must have a functional defibrillation for emergency use. This slide is important for your exam also. Find this figure inside the book and read it, read the related text, and also learn the solution. First of all, you should get the challenge, get the problem, and after that you should learn the solution to solve that problem. We have a problem in this, we want to explain a problem in this figure. As you can see, systolic pressure gradient between left ventricular and aortic region across a stenotic aortic valve. And as you can see, the hatched area, the hatched region, has been decreased after insertion and aortic ball valve or replacement aortic valve with the aortic ball valve. As you can see, we have a marked decrease in systolic pressure gradient. Gradient means this hashed region, the difference between the pressure between the ventricular and aortic pressure. I emphasize you should find this figure inside the book and read the related text and related example also. We have an example inside the book and you should learn it. You should you should read the equations, the related problems, and learn the solution also. In previous slides, we have talked about some stenotic problems inside the vessel, between the chambers, in some valves inside the heart, and we talk about some gradient between the, for example, pressure of two sides of a valve. This is because the important of the valve size, valve orifice size, and we should calculate the area of a valve orifice. The areas of a valve orifice can be calculated from basic fluid mechanics equations. Bernoulli's equation for frictionless flow is this, and in this equation we have PT as the total fluidic pressure. P is for local fluid static pressure. The second part of this equation is for potential related pressure, and the third term at the right side of this equation is related to kinetic part of the pressure. In this equation, rho is the fluid density, g is acceleration of gravity, h height above reference level, and u is the fluid velocity. Also, in this model, in this schematic, we will measure P1 and P2. P1 is for upstream and P2 is for downstream static pressure. As you can see, we measure here. And velocity U is calculated for minimal flow area A at location 2. This U is the velocity at location 2. Based on the main Bernoulli equation, we have some assumption. The first one is the frictionless flow for the model. The second one is that equate total pressure at location 1 and 2. Also, the difference in heights is negligible, and the velocity at location 1 is negligible compared with U, the velocity at location 2. Therefore, based on the main equation, as you know, PT is P, static pressure, plus rho GH plus rho U squared divided by 2. We can rewrite this equation for location 1 and location 2, PT1, P1 plus rho GH, because we assume that the height is as the same, plus rho u1 squared divided by 2 pt2 rho gh plus rho u dou squared divided by 2. Based on this assumption, we can remove this part, and we assume that the total pressure at location 1 and 2 is as the same. Therefore, PT1 equals PT2. Therefore, P1 plus rho GH, we remove this part, equals P2 plus rho GH plus rho U2 squared divided by 2. Because of this assumption, we can remove these terms from two sides of this equation, and therefore we have P1 equals P2 plus rho U2 squared divided by 2, and now we can write this equation. Difference between P1 and P2 is the kinetic term at the second location, and using this equation you can find the velocity. And because of this simple assumption, we have a known area A, and the flow of the liquid, flow of the fluid, which can be written by this simple equation. We can replace the U by F divided by A. We can find this equation. As you can see now, we are able to calculate the areas of a valve orifice here. The area is proportional to flow, and also some other parts here. The difference between the pressure, higher differences leads to a small orifice area, as you can see. In practice, there are losses due to friction, and the minimal flow area is smaller than the orifice area. Hence, A becomes with this equation, where CD is a discharge coefficient. This has been found empirically that for semilunar valves, septal defects and patient ducts, CD as 0.85, whereas for mitral valves, CD is 0.6. Also read this example. Please read it. Read it by yourself. Maybe this is a good choice for your exam. Effects of potential and kinetic energy on pressure measurements should be considered. In certain situations, the effects of potential and kinetic energy terms in measurement of blood pressure may yield inaccurate results. Based on Bernoulli's equation, the total pressure of a fluid remains constant in the absence of dissipative effects. The static pressure P of the fluid is the desired pressure. It is assumed in a blood vessel when the potential and kinetic energy terms are zero. The effect of the potential energy will be considered in this slide. We first examine the effect of the potential energy term on the static pressure of the fluid. For clarify, we use a simplified schematic for pressure and our parts of the body. We assume that here is the level of the heart, and this is the ISO level or zero level of the reference level for the heart. And we want to measure in various situations. We want to measure the pressure in various situations, in various location and situation. First of all, I want to start from some simple situation. No corrections need be made for the potential energy term while the patient in a supine situation or lie on the back. Also, the sensor, if is placed at heart level, we don't want any correction. We don't need any correction because the sensing location is at the level of the heart. But in other positions, however, when the patient is sitting or standing, the long columns of blood in the arterial and venous pressure system contribute as hydrostatic pressure, as a term we have seen before, rho GH. In the erect position, the arterial and venous pressure both increase to approximately 85 millimeter Hg at the ankle because of that columns of blood we talked before. And when the arm is held above the head, the pressure in the wrist becomes about 40 millimeter Hg. The sensor diaphragm should be placed at the same level as the pressure source, pressure reference, at the level of the heart. If this is not possible, the differences in height, the difference in height must be accounted for, and for each 1.31 centimeters increase in height of the source, 1 millimeter Hg must be added to the sensor reading. In this slide, you can see convenient reference point or level of the heart in some anatomically well-known locations, and we should consider this point as the reference point for our heart level and pressure reference point. In this slide, we will talk about the effect of the kinetic energy. As you remember, the kinetic energy term rho u squared divided by 2 becomes important when the velocity of blood flow is high. If the velocity is low, the kinetic energy is also small. When a blood pressure catheter is inserted into a blood vessel or into the heart, two types of pressure can be determined: side or static pressure. As you know, we measure the static pressure in this location. vertical direction, as you can see, and end or total pressure. End or total pressure can be recorded here for two sides of this orifice. Side pressure implies that the end of the catheter has openings at right angles to the follow. We have a flow direction here, and if we record the pressure at right angle, we are recording the side or static pressure. In this case, the pressure reading is accurate because the kinetic energy terms is minimal. If the pressure port, remember that, if the catheter pressure port faces upstream, the recorded pressure is in the side pressure plus the additional kinetic energy term rho u squared divided by 2. And if the catheter pressure port faces downstream, the value is approximately rho u squared divided by 2 less than the side pressure. When the catheter is not positioned correctly, artifacts may develop the pressure readings. For these two cases, imagine you are in a river, and if you face upstream, you will sense more pressure from the water inside the river. And if you face downstream, your face will sense less pressure. In this slide, the effect of the kinetic energy has been considered by some numbers. As you can see, in the specific situation where the pressure, the total pressure is low, for example, at vena cave and pulmonary arteries, the percentage of the kinetic energy is higher than the arteries. You can see the percentage of the kinetic energy is higher in the vessels with lower total pressure. As shows, there are situations in the aorta, vena cava, and pulmonary artery in which the kinetic energy term is a substantial part of the total pressure. For the laminar flow case, this error decreases as the catheter pressure port is moved from the center of the vessel to the vessel wall, where the average velocity of flow is less, and this is a solution for our problem. The kinetic energy term could also be important in decreased situation in which an artery becomes narrowed.